This meeting is being recorded. Thanks for speaking up. I think 30 some students would have missed out. Anyway, so let's go back there. I used to like WebEx, now I'm starting to. I can't sing very well, so here's the, I don't know if you can hear the music. And also, I heard one of your classmates was featured. I saw this video on YouTube. It was very nice. If you haven't seen it, I hope you all see it. It looked like it was very well thought out and well spoken presentation. I just wanted to say I might have been the first to see it. Not bragging, but so this is my setup at the moment. I've got the camera that I found somewhere in my office, and I've got the I got my paper. Just the reason why the setup is so strange is because this is a microscopic camera, so it has to be far away. If I'm really close, you won't be able to see the page very well. But for this reason, I'm not going to be able to change the way things are positioned well. So just speak up if you can't see anything. Maybe I'll try to improvise on the spot. When it comes down to designing, obviously, you may see some sort of sequence. And this is just one sequence that you might see. You don't have to go by this sequence exactly, but this is something that I would go through, and you might find, some other people at the school go through this sequence similarly. I like to start with something more broad, more general than something as small as 1 tooth. So we can start with, say, arch. Is it maxillary or mandibular? Now you might say, wow, that's really obvious, Dr. Chodek. Do you think we'll make mistake in terms of whether it's a maxillary or mandibular arch? Well, I've graded last 2 times, I believe, for this course, and there are times when I find lingual bar on the maxillary arch. I see palatal plate on the mandibular arch. So yes, we do see students making mistakes. This happens in clinic too. Once you have identified your arch properly, then you should look at Kennedy classification. You know very well by now, although a lot of us have been away from dentistry, and I noticed that with the D4s last week, some of them came back for graduation requirement. It's like we forgot dentistry altogether. Of course, it doesn't take very long to kind of get back in the swing of things. But if you remember Kennedy classification, it really helps us determine what kind of design we're going to have. Have modification that's part of that. Another kind of a broad, general thing you need to be aware of is, is there anything unique to the anatomy? Is there soft tissue undercut? Is there palatal torus, lingual torus? Whatever that might be, you should also note that before you think about other smaller things like rest. Give me one moment. I need to get rid of that. It's going to get annoying really quickly, but bear with me. So smaller things like rest, guide plates, clasps. If you have retentive portion, you should have, in certain situations, as you know, the reciprocating clasps, minor that connect all these smaller components to the major connector. Where's the base? Where are we putting the denture? And what is the material that metal framework is made of? So those are all important factors that you should have in your prescription in the clinic, especially for this practical exam. you should have these. And I'll go over these again in detail. I'll actually show you the grading sheet that I'll be using, okay? Someone had asked me if I could talk about lever system again. And, you know, again, I'm not great in physics. I had to take physics multiple times. I took it in engineering. I failed, and well, not literally, but then went to liberal arts and I took it again. I did okay, and in grad school. So it took me a while to understand physics. So, but now I really enjoy it. I appreciate physics. When you look at different textbooks, different sources online, especially, you might find drawings labeled differently. Okay, but this is how I remember. Okay, when I think about lever, I'm looking at load, fulcrum, and effort. And sometimes you see maybe load is power or effort is power. You may see terms used a little bit differently, but essentially they're all same. On the far left, we have class 1 lever situation. In the middle, class 2. Far right, class 3. Just for simplicity's sake and for presentation's sake, I'm just going to say effort is actually where the edentulous area is. So E for effort, E for edentulous area, okay? Usually, fulcrum on RPD design, can anyone say which provides fulcrum? Let's see if I can see the chat box here. Oh, I see. I need to turn it on. Okay. Yeah, by the way, obviously I didn't doctor those pictures. I mean, they were freely given to me, not because I forced them to share them with. Anyways, yeah, happy birthday. Yeah, REST. So REST are going to be providing some sort of fulcrum for our RPD. And obviously then load comes from, anybody again? You know, if I find it still very challenging to do this virtual online lectures because I don't get to see many of your faces and get much feedback. So just type anything. It doesn't have to be right. Occlusal force. Okay. What else? What else on the RPD? Yeah, clasp. Great. Occlusal force definitely is a load. It's a type of load. But if I'm just thinking, thinking about the RPD components, what part of the RPD is actually going to cause some sort of load, some sort of stress, basically, on the teeth? That would be clasp. Okay, so far so good. Let's look at class 1 lever specifically. I try to rearrange these pictures so that they're almost lining up. Effort, as I mentioned, is edentulous area. Okay. Manny, you mentioned occlusal force is load. Yes, it is. But if we just look at load as in if I press down on the occlusal surface of the denture teeth, yeah, there's going to be load. But just imagine that load gets basically transmitted to the clasp tip. So you have to think, what is the consequence of putting occlusal force to the edentulous area, which is effort? Well, the consequence of having occlusal load is there's going to be force transmitted all the way down on that metal framework at the very tip of that clasp. If it's engaging or if it's retentive, it's going to cause stress or load onto that tooth, okay? For the simplicity's sake, let's just think that way. Yes, there's going to be load on the soft tissue that's in the edentulous area, but I'm not really thinking about that when we think about the lever system that's created in this RPD metal framework, okay? Fulcrum, obviously, you can't see it, but if I told you there's a rest on the distal of that canine or cingulum, that's where the fulcrum is going to be. So as I push on this occlusal denture teeth area, this is going to rotate cross, okay? Because it's going to push into the soft tissue, driving that edentulous portion or denture teeth area downward or toward the tissue, and that clasp tip on the canine, the mesial of the canine, will move up. Okay. This arrangement is perfect for creating class 1 lever. Okay. Again, load at fulcrum at the rest and edentulous area as effort. So what is our class choice? Okay. Well, the edentulous area could belong to class 2 or even class 4. For class 4, it's in the anterior, as you know. We just have to flip the situation. It's the same setup for the lever. Okay. So what are our class choice in this situation? Can anyone just retentive clasp? I don't know if that was a question or not, but so let's say okay, so there's I-bar, Rottweiler, circumferential, but we have to think because of this large edentulous area that is actually allowing this movement of the denture to happen during occlusal load, we have to consider what class design is less detrimental to the tooth. Almost every single RPD design potentially is detrimental to teeth. That's probably one of the reasons why, from our point of view as a dentist or clinician, RPD is not at the top of the list for treatment option. You know, if we can do implants, why not? We can get rid of all this bulk, all this, and get rid of all these potential detrimental forces. But if this is the only option in the plan, well, at least we have to design that something that is going to cause the least amount of damage or stress on the teeth. So circumferential clasp, for this reason, for any edentulous area this extensive, so for example, we call this distal extension or free end saddle, circumferential clasp is usually not at the top of my list. It's I-bar at the top if I can use it, or Rottweiler. Okay. Obviously, if I can do I-bar or RPI design where I have the I-bar in the mid-facial or mid-buccal of the tooth, mesial occlusal rest, plane on the distal, that would be ideal. If I can't do that, I'm going to do Rottweiler, get rid of mid-facial I-bar, put a mesial facial or mesial buccal retention with the retentive Rottweiler clasp, and have embracing or reciprocating clasp on the palatal side or lingual side, and a distal guide plate. Okay, so far okay? Okay, I won't say anything, so I'm going to go forward. I just talked about RPI. That's a classic class 2 lever system. Line things up. Effort in the edentulous area. Okay. Fulcrum, now, if it's a class RPI design, we know, and maybe it's a review for everyone, or most of us, that it's going to be on the mesial side of the tooth. Okay. So that lines up with the fulcrum. Usually that I-bar is going to be somewhere in the middle of the tooth. Okay. Now, depending on the people that are associated with I-bar design, you may see slight variation, but that's just for simplicity's sake, we're going to say mid-facial. Okay, not slightly mesial to mid-facial or slightly distal to mid-facial, but mid-facial. Okay, that's where the load is going to be, because when we have an occlusal force, the patient bites down in this edentulous to this tooth, it's again going to rotate clockwise. Okay, as it rotates clockwise, fulcrum is on the mesial. That I-bar potentially can put load on that tooth. Okay, because it's engaging. However, because it's the way it's designed, because it's what we call infrabulge, not a suprabulge, as it pushes down, that I-bar doesn't actually go upward. Okay, it might go slightly downward and just imagine turning that clockwise. It might go slightly downward, rotating down, and slightly distal. Okay, it might even go slightly mesial if you bite down hard enough, if the soft tissue gets pressed down hard enough. So the whole thing, in a way, with the fulcrum on the mesial, it just kind of rotates, kind of goes forward, down. Okay, so really, I'm not luxating that tooth away from the tissue. So for that reason, class 2 lever on free end saddle or distal extension is much less detrimental than having fulcrum on a distal that creates class 1 lever. Okay, again, class choice B, not circumferential, but some sort of stress breaking design. Again, I-bar is at the top of my list in terms of design. If I can't do it, I'll pick lot wire. Now, there are various reasons why I can't do I-bar. Can anyone think about, just shout out why I can't do I-bar? Shallow vestibule, yeah, so anatomy. Deep soft tissue undercut, so this is all anatomical limitations. Tilted tooth, yes, if it's severely buccally tilted, and I try to do enameloplasty, but I still can't get that undercut to go away to 0.01, I have to consider something else, okay? Other than those two anatomical considerations, sometimes if we have frenum attachment, and let's say we're trying to design this around premolar, maybe canine, and I've got that buccal frenum really coming onto the tissue near the gingival margin of the tooth, I can't, because this infrabulge I-bar has to come down away from the gingival margin at least 3 millimeters. So you actually see tiny little glimpse of frenum there on the picture that may be maybe at most 2 millimeters away, but it is away from that I-bar. So that allows us to do I-bar, but if the frenum attachment is there, even if there's no tissue undercut, whether it's the soft tissue or the hard tissue from the tooth, that frenum alone could potentially prevent us from. Have I seen oral surgeon repositioning that frenum so that we can allow I-bar to happen? I have not. You know, that might be kind of overkilling, but you know, that's consideration certainly, but I just haven't seen that at all. Okay. Okay, lastly, class 3 lever. This is probably the most favorable situation in RPD design situations because, well, we got edentulous area that's bounded by teeth. Okay, so it's somewhere in the middle. Fulcrum, where's the fulcrum? I kind of gave it away already. Where's the fulcrum on this picture, on this design? I think 3 months ago, everyone would be jumping onto this question. I don't know, maybe it's just lattice. Okay, no, guessing is good. Again, I told you it takes time, some time getting a swing of things. No fulcrum, interesting. Okay, rest. Which rest? Mesial rest of 2. Okay, both rest. To me, it depends on who you talk to even. To me, it depends on where this occlusal force is going to be. And this is what I mean. For example, the fulcrum could be on mesial rest of that tooth. Okay. I'm not going to guess what tooth it could be, mandibular arch, maxillary arch. It could be 14, 15, but whatever. That molar, I'm going to call it a molar. Okay, that the fulcrum could be on that mesial rest of that molar. When I press down on that RPD component or the RPD, so meaning it's going to turn again clockwise. Okay, everyone follow that so far? So in that sense, the clasp tips on that tooth, on that molar tooth, are going to go downward. Again, it's rotating around that MO rest clockwise. As it's doing that, the anterior portion of this of that premolar, that clasp assembly is going to lift away from the tissue. Good so far? Sorry, I couldn't, maybe in another world I can have a video of this, but I couldn't do that. So picture that so far, okay? So right side of the screen is going downward, fulcrum is MO rest. Left side of the screen, the clasp assembly is going upward occlusally away from the tooth, away from the tissue, okay? That's why the load is on that premolar. Fulcrum is that MO rest. Well, edentulous area, as we said, is in between, okay? Question is, if that rest is the fulcrum, is it not class 1 lever? That's a great question, but just again, look at this drawing. Let's just again break it down, okay? In order for class 1 lever to happen, fulcrum has to be between the load and effort. But in this situation, the effort is in the middle. So I think I'm going to have to go back and maybe clarify certain things. And I'll answer the second question, actually. What I need to clarify, I mentioned that the class on the right side moving down. First of all, in a class 3 situation like this, class 3 situation, it's not going to happen often because this is tooth bound, not a lot of edentulous area in play. It's just not going to move around that much. But I'll give you this clinical scenario. If the patient, for some reason, decides to get his or her fingernail under that anterior clasp assembly, fingernail over that buccal clasp, and pushes downward, potentially it's going to rotate on that MO rest of that molar. Can you all picture that? Or patient has a very sticky food and that goes right onto the occlusal of that premolar, and patient opens his mouth, it's going to drop there, pivot fulcrum on MO rest on the molar again, okay? So when that happens, it still sets up for this order: load, effort, because again, effort, yeah, you have to really look at microscopically. That tip is in the mesial buccal, effort, sticky food is on the occlusal surface, and fulcrum on MO rest. So that order is still the same for class 3. If you flip the situation, and again, this time, if you didn't get it the first time, I'm going to say, hopefully you can get it this time. This time, let's say I put sticky food on that molar. That clasp assembly on the molar starts to come down. It's rotating on the rest on that mesial tooth, which is that premolar, okay? Now, again, the order is, but it's load on the right, effort on the occlusal surface of that premolar, okay? I'm sorry, did I say load on the right? No, load on the right, effort on the occlusal surface of the tooth, and fulcrum on the left. So the reverse sequences, or the order is reversed, but still class 3 order. So that's this still makes a class 3 situation, class lever wise. Okay. Do these fulcrums cancel out? You know, again, I'm not a physicist. I don't know if they do cancel out, but I can tell you. And again, any tooth-bound situation, tooth-bound candidate class 3, we just don't see a lot of movement or motion of the RPD framework. Maybe because they cancel them out. If there's a physicist in the audience, just feel free to tell me I'm wrong or I'm right. The reason I'm reading a question now, the reason I'm saying it is class 1 lever, because if that MO rest is fulcrum, the distal clasp on that very same molar is the load. The lattice is the effort. Yeah, so this is what I needed to clarify. I mentioned that instance where I call that MO rest as a fulcrum, I mentioned that the clasps are actually moving down. So it's not actually putting load on the tooth. Remember, if the clasp is moving downward from the tooth, it's not going to engage. So that's not a load, in my opinion. Before I confuse anyone, can I go on? Yes, no? This was so clear in my head, and every time I talk about it, I get a little bit enlightened, and I present it again. But if we want to talk about class lever systems again, we can do that before next Monday. But let's just go through the actual practical exam. But just to tell you, class 3 classification, really no reason to not think about circumferential. When would I not want to do CC? What might be benefit of, say, doing an I-bar on the anterior tooth? Anybody? Why would I do an I-bar? Better aesthetics. Yeah, if I have an infrabulge, infrabulge clasp that goes up in the soft tissue region and comes down just a little bit, that might look better, okay? I-bar for anteriors and premolars, better flow over to, so reasons. Well, food trap, potentially, because there's so little contact in the tooth. But you have to assume that any RPD component, everything about RPD is just a nightmare in terms of food trap. So, saying that I-bar is so much better than circumferential clasp because it's a less food trap, that aspect alone shouldn't be your decision-making factor. Does that make sense? Even I-bar is going to trap food. Is it going to trap less food? Potentially. But there are other factors that decide or justify picking I-bar over something like superbulge class like CC, because it's better aesthetically and so forth. Less force is, again, legitimate. Pick I-bar over circumferential. So those are, the fact that you're all thinking about different factors, that's the most important part about RPD design principle. If you just think, oh, for aesthetic reasons, I'm going to pick this every single time, regardless of what kind of force I'm putting on a tooth, that will be very detrimental to the patient. So is that good enough for now? I'll move forward. So what I'm going to do, I'm going to switch to my camera setup here. And the other thing that's going to happen in my office, because I'm not moving around, the light is going to go off every so often. Does everyone see that Mac torch? Great, thank you. So this is the actual exam sheet that we've used in the past. If it's different, it's not going to be significantly different in that everything I say is basically invalid. But you will first see at this area where it's going to ask you to fill out some information, okay? I answered that question earlier. Do you know who the grader is? And the answer is me. So I am the only grader for this entire practical exam this year. There are some good reasons for that. I can't think of a bad reason. When I first graded, so that's about 2 years ago, and submitted my grading to Dr. Ferone, they came back very quickly. Dr. Ferone said, "You are way too kind." So this is what's going to happen. If you leave anything out, and again, this is based on how all practical exams every single year has been graded, you lose a point. We're looking for you to be accurate as well as comprehensive. well as complete, okay? So please, I don't care if you make up names, I don't care if you make up address, just put something in. It should be, we're not doing it just so that you're wasting time, but practice. If you remember, in fact, if I say, so I'm gonna start writing, and hopefully this will be very visible to you all. Dr. Simpson, provider number, something easy like that. 1 Springfield Road. Phone number 555-34. Area code Baltimore. Lab. I don't know. Just I'm in the Simpsons family mode. So Bart Best Dental Lab. Lab address next door, Springfield Road. That's no one knows where this is, but let's just say Spring town of Iowa and the Springtown. Oh, you can't see me. Okay. So far, okay. Patient, Marge Simpson, doctor's treating. Whoops. Simpson. I haven't written things in a really long time. His own wife. So complete this area blank. So far, okay. You should all, no one should be getting points off. Okay. Just make sure you look from the very top, left, right, and down. Okay. I'm gonna keep going here. Now you'll be given some sort of description of the patient's. So it will say the patient's tooth 5. I'll just write it down here so we can all remember. And again, it won't be written here. It will be on a separate sheet, I believe. Teeth 1 through, let's just make it up. 3 are missing on the maxillary. So it's 5. I'll just create a violation. And here comes 12. This is what happens to me too. I'm still making up a lot of lecture stuff, but 14 through 16. Okay, so let's just make sure. 1, 2, 3 is missing, 5 is missing, right across the street. 12 is missing, 14 through 16 is missing. Okay, so far so good. So the scenario here, an example we're going to go over is a maxillary arch. Did I tell you that we should think about general things like arches? So hopefully you're not going to even look at this mandibular section. If it tells you it's missing certain mandibular teeth, I hope it's the other side, okay? But this is it. Now, if you go ahead and do this, I don't mind, okay? Or that, okay? So, and the clinical scenario goes on to say, well, there are no anatomical challenges, meaning there's no soft tissue undercut or severely tilted teeth. So everything is ideal, okay? It's just basically giving you what's missing in terms of teeth. There's no torus, so the rest is kind of up to you to design. And again, stop me anytime. I'm just gonna, oh, there was a chat. I'm sorry, I missed something. Oh, okay. So yeah, if you remember, we talked about general things. We already got it down to maxillary arch. What's next? Well, I'm going to look at Kennedy classification. What Kennedy classification would this be? KC1, okay? I agree with that. Modification. Okay, let's review. Candidate classification 1, because in 1, we have to have bilateral edentulous areas, okay? And teeth enter to that. For that reason, this is class 1, okay? I told you missing teeth were 5 and 12. Oops, I'm a little bit far away. So 5 and 12. So for that reason, those two will be modification spaces. So class 1 mod 2, everyone's correct. When I was a student, I used to do this. I mean, if you do this, please erase them if you can. But we're also asking you to draw the design in colored pencils, which I find a little bit difficult to erase. So if you're going to make little notes, little scribbles, it starts to get really messy. That's the other thing. We want neatness in your lab prescription or work authorization. In essence, it's also a document. So when things get messy and they get smudged like this, and we start to kind of lose accuracy or quality of overall work authorization. See, as I'm erasing it, it's just leaving all these so-called pencil skid marks. So if that would be great. And again, in the past, I didn't really look at that as something to take points off. Extra sheets. So that's a question that I'll ask because I know that we're using proc. I'm not sure if you start to shuffle a different sheet. I'm not sure if the proctorio will go berserk and say, "Dude, you just you're cheating." It's outrageous that it will think that it's something. But if that happens, let me ask. So okay, Kendra says print as many sheets as we want. Well, okay, yeah. So if that's the case, you should be able to use it as like a note for you to just doodle instead of doing it here. Okay. So, but whatever works for you, just try to keep it neat. All right. So we talked about candidate classification already. So again, if I have a separate piece of paper, I'm going to say candidate class 1, mod 2. Okay. Yep. Remember the class level review that we just had? I'm already thinking I-bar, RPI class design. There's no anatomical limitations here, so I'm going RPR wherever I can. Okay. What would be, so I kind of started thinking about after candidate classification. I already thought about, okay, what type of class assembly I would have. What would be, just someone shout out, what would be the next thing I will start actually drawing? Yeah, so I'm with you on REST, and that's because even though that's a small part of the metal RPI framework, it's very easy for me to go to the edentulous right away. Also, by doing that, I'm setting up my whole drawing correctly. Because my rests are in the wrong place, that means I picked the edentulous area incorrectly. Does that make sense? So I told you we're missing teeth 1 through 3 and 5. So we got a tooth on 4, okay? Now, I'm already set on doing something like an RPI design. So most likely, I'm not even going to consider doing any kind of distal rest next to edentulous areas. Make sense? We've got an edentulous area here where 5 is missing and 12 is missing. Okay, well, that means I have a tooth here. I'm going to try to see if I can put mesial rest. Now, I got to change to blue pencil. So I'm going to be drawing half circle here as an MO rest. Wow, that really doesn't show up, huh? I'm going to thicken the line here. And just remember, I'm doing this just so that you can see that a little better, maybe. Okay. Bilateral so easy because I'm going to have symmetrical design. There's no reason for me to do, hey, let me mix it up. I'll do RPI on one side and route wire clasp assembly on. There's no reason for that. Patients a lot of times prefer symmetry. So here's my other rest. So far, okay? So M on both teeth, no distal rest so far. What will be the I would draw? Plates, tube tooth, guide plates. I actually go to tube tooth. Just remember, I'm just staying with the idea of edentulous area. So I'm going to stay near the edentulous area, and I'm going to draw my tube tooth. And again, it's bilateral. So I'm going to draw something like this. Right in the middle, there's a circle indicating that retentive metal component that's going to help retain. And I'm drawing a dotted line around the tooth like that to indicate this is the entire thing, tooth area, okay? You may also draw a thickened line on the buccal, and again, just to kind of complete that circle of tooth. Okay, and I'll do the same thing here. Remember, you can ask, in terms of RPD design, including this drawing, you will get different answers when you ask different people. Well, Dr. Choi said, stay in the edentulous area and draw all the components on it, around it. That doesn't mean you have to do it this way. Whatever works for you, as long as you're not missing things, okay? Those are my dotted line, and that's my clear bold line with a circle in the middle to indicate, yeah, that still doesn't show very well. Let me see if I can turn on the light on the camera, see if that makes it any better. Nope. Sorry. So that's it. What will be my next? So I'm kind of done with the edentulous area. I got a question. Can we review indications, contraindications for tube tooth? Yeah, you know, I think of it very simply. You know, if I'm replacing, if I'm having one tooth replaced, I go with tube tooth. In other words, think of it this: would you? Don't worry, I'll answer all these questions. When would you think of a lattice? Dear, I'm asking you this. I'm putting you on the spot. So when would you think of lattice? That's it. Why? Well, if you if you have made RPD metal framework, and maybe there's a lab technician in your class. I made one before dental school, and I understand in order for lattice to work out, you need to have space. If you don't, and if you try to squeeze in a lattice in this short span of space, that lattice just doesn't hold up, okay? So for that reason, you've got to have space, and for that reason, we use it. Likewise, if you try to put two teeth design, so meaning retention on these, let's say missing teeth, on such large teeth especially, it's going to be very difficult to retain both denture base and the tooth, right? So if you think of it that way, it should become pretty simple. One tooth, tube tooth, almost all the time. There are exceptions, but almost all the time. Lattice and multiple teeth, at least two teeth. That's not a bad way to think. Now I'm gonna stay with the tooth idea and answer any questions on that. Don't you need rest? Okay, I'll come back to that. Would you always use acrylic retention lattice for multiple missing teeth in posterior arch? Use acrylic retention lattice for missing teeth. Or if the patient has excessive occlusal force, would you use multiple tube teeth like how, okay, for example, if the, yeah, so again, if you think about patient with high bound, I still don't think of tooth as a great option. I want that bulk of that molar to be retained as much as possible, and that little pin for a large molar tooth just doesn't fit for me a lot of times. If you're asking whether you could pick retention lattice versus metal base, I don't know if you guys remember, but metal base doesn't have kind of, I'm going to pick. So lattice kind of looks like this. I'm just going to play here with windows where there's retention provided through those windows. And then we've got something like denture metal base that has these tiny little metal projections that help retain denture base in the teeth. Some people say this metal base may be better for someone with high biting force because this whole thing is one piece. People argue that, well, if you're picking this over the lattice, you may actually have less of a retention because these tiny little projections sometimes don't retain teeth as well as this lattice type. I think it's just, you got two sides of argument of each one, but I certainly wouldn't pick two multiple teeth, especially posterior region, as my go-to. I'm gonna say, is that good? I can't say this person's name because this person asked me privately this question. Thanks for asking that question. So let me go back a bit. Okay. So my question was, am I done here with this edentulous area? And somebody said, don't you need the rest on the opposite side of the tooth? Absolutely. So I'm going to put rest here. In a way, we're reviewing almost everything about RP. This course, potentially we're reviewing today. Unfortunately, I'm sorry, but I have to make sure I get time before my daughter's daycare closes. And again, I apologize we ran late. The faculty assembly meeting went beyond my expectation, but we're reviewing everything, and I'll try to review everything as we go. And if we get short, I'll find another way to get this review to you, or the remainder of the review to somehow. Okay. Someone said, okay, we got to complete this edentulous area by having a rest. Okay, absolutely. If you don't have another rest, because there's another tooth here, you're gonna lose points. On this canine, just tell me what kind of rest you would put, and hopefully you'll have a reason. Okay. Marginal ridge rest. Now, marginal ridge rest. How many options do we have? Manny, I'm gonna put you on the spot now. See if I can draw canine. Manny, what? It's almost a deja vu. I feel like I've asked you a question like online like this on the spot, and then your answer was what? So you said marginal ridge rest, right? You didn't mean like marginally inferior rest or superior rest. You meant marginal ridge rest. So how many options do we have? Yeah, great. So how many options do we have? Hold on. Manny still got has to. Yeah, two knees rest on both sides. Yeah, absolutely. Manny's still going what? Okay, I'm gonna two options, right? We got distal or mesial. Yeah. All right. See, I told you you're all gonna need some time getting into dentistry. So in essence, we got three options. Okay, distal marginal ridge rest, mesial marginal ridge rest, or cingulum rest. Okay. Again, depending on who you ask, you're gonna get different preferences, biases, whatever you want to call them. You ask me, I like cingulum rest on canine teeth. The reason is, I like something to be rather in the middle. This makes this whole rather symmetrical, okay? Now, before we talk about which marginal ridge rest you would like to do, can someone tell me what the shape, and again, this will be tricky because I'm the only one drawing here. Tell me, I'm gonna draw a few different ones and tell me which one. And again, depending on who you ask, this might be different. So I'm going to draw, let's say Manny picked a mesial marginal ridge rest like this, okay? Manny drew this one, and let's say Manny just pick a name, or I'll pick a name. Clive in the audience, pick something like this. Is everyone still with me? I hear ringing in my ears, so I'm not sure. Okay. Manny picked this one, and Clive with a C, right? Picked this one. Is there a Clive in your class? Am I mixing things, mixing people? Okay. Oh, class name. Okay, so I was right. So Kevin. So Kevin picked this one. Which one is correct? Okay, for Kevin. Anyone like Manny? Anyone think? We got one vote here. Anyone like Manny's design? Okay. Why is this better than this? Why is it better finger protection, larger or longer rest than this? It looks like. Okay. I got an answer. I won't say who. Better retention. Well, does the rest provide retention? Provide encirclement. Another private answer. No, I don't think either is wrong, but I'm just asking which one would be better. And just asking to see and trying to see if you guys can come up with a good reason. Whatever you pick, not just in dental school, but afterward, I hope you do some removable pros. You can say, no, Dr. Choi, heck no, I'm not going to do any removable because I hate it. That's fine. You got to have stability. Okay, now, okay, rest. What is the word that's associated with rest? It's support, not stability. So you should all be saying one of these two will give us better support. And yeah, by sheer surface area, this gives me better support than this tiny little rest. Does that make sense? Someone said maxillary canine cingulum is more pronounced. Yeah, so there's some economical consideration there. The other thing is I can actually afford to have a larger rest like this. If this was a lateral incisor that's much less in terms of size, something like this, if I go ahead and have a long rest like that, I potentially really damage the tooth. But canine being a large, and I want to have as much support as possible from the rest, I'm going to do something like this rather than having small like this. Does that make sense? Let's see. Otherwise, it will be reciprocal. Oh yeah. So someone mentioned again privately encirclement. I think I can see that as a valid answer to why I might have a longer rest like this. You know, I don't like this. I don't like this either. I told you I like cingulum rest, but please just have a. I'll tell you this. Try not to do mesial rest. I'm giving away an answer here, I think, for the practical exam. Try not to do a mesial one, and I'll tell you why. If I did a mesial rest, and here's the minor connector, and I'm going to complete the drawing here. I'll try to do more drawing. Where was I? Oh, so here comes, yeah, that's right. I'm going to have another rest. I'm really getting confused. So 5 is, okay, I'm going to X that out. So there should be no line here. Sorry. See what happens if you don't draw neatly. So here's my mesial. I should have drawn the tooth first. Watch me fumble. Again, takes time. Whoop. Okay, there's a little bit more blue left. So the problem or the issue I see with this one compared to having distal, oh, I could have kept that line there, couldn't I? Is in terms of comfort, patient finds when we have metal going to anterior teeth very closely, right? So I'm just going to draw whatever, okay? Just imagine those are maxillary anterior teeth. If the metal component is very close to the anterior teeth, they find it very uncomfortable. Yeah, foot trap too, but remember, foot trap is going to happen everywhere, okay? But it's really, you have to think a little bit more, you start to see this in a clinical situation when you start seeing patients. Some of these nuances, you can't see it now because it's paper. but just imagine having metal part close to your anterior teeth, okay? And try to say 66 or Thursday or something, some words similar to those sounds, S sounds or TH sounds. The tip of the tongue wants to be near the anterior teeth, the palatal side, somewhere in that vicinity, okay? If you have a lot of this metal component riding up the anterior portion of the palate, oftentimes patients hate that. So you could make an argument that, okay, I put a distal marginal ridge rest like this one here because I wanted to put as much metal, that's what I meant by light turning off. All right, can you all see that? I'll just keep going. I wanted to put as much metal component away from the anterior teeth of the maxilla as possible. That's a good argument there, okay? I'm getting out of so much on the rest. I am losing. But again, I still like singular and rest because I don't like that long marginal. I don't know, I'm driving people crazy. I don't like this long marginal ridge rest because it's going to flex. It can potentially break. Singular and rest works just fine. So on the exam, if you do singular and rest, I'm not going to take off points. If you do distal marginal rest, I'm not going to take any points. Mesial marginal ridge rest, again, I think someone is asking. I can explain why we're avoiding that. So let's do this again. Whoa. I'm going to try to do this right this time. That's my diamond-shaped canine. That's my premolar. And we've got an edentulous area here. Okay. Let's draw the rest of the teeth. I remember my dental anatomy. Well, my center incisors are not symmetrical, or my lateral incisor, peg lateral. So far, okay? So edentulous area here, I'm going to put, this is a premolar, so I'm going to say this is 4, this is 6. The question was, why not mesial ridge rest? If I did that, so I'll draw this, and we'll rest. Okay, minor connector. Here's my tooth, something like this. And I went ahead and really extended. Okay, compare that to distal marginal ridge rest, which the minor connector will end up coming away this way. So we've got, again, this may be, at the least 5 millimeters in the mouth. That could be a mile. Okay, so for that reason, having a metal component away from the anterior teeth where the tongue likes to function for speech, that might be an ideal thing. So to clarify, are you saying do not put mesial rest on a canine if there's also distal rest, or do not put mesial rest? So try not to put mesial rest on the canine at all if possible. That's the clarification. You're going to put one rest. It's going to be mesial, singular, or mesial, but pick distal one or just pick distal. How about that? Because that puts a lot of the metal componentry away from the anterior teeth as much as possible. Can you put rests that come off the tooth to? Yeah. So that's what happens in reality. Again, on a two-dimensional image on a flat paper like this, you can't see what's happening. Well, what's happening to that tooth area? There's a whole lot of metal componentry going on. There's also guided plate that you can't see. If I drew it correctly, there's distal rest. There's a metal part coming down. There's that little metal component that comes out to retain the tooth. And here is what might look like, that distal marginal ridge rest for that canine. So do we use singular rest if it's next to a distal extension? Yeah, that's a great question because you're thinking about class 1 lever again. So if this tooth was missing and you wanted to keep, prevent creating class 1 lever on this case, right, AJ? You definitely don't want to put distal rest for sure. Um, I don't know. You could talk to different people about this, whether it creates class 1 lever or not. To me, it still doesn't if you put single and rest. If you want to be safe, put mesial marginal rich rest. You certainly won't create class 1 lever situation because your fulcrum is way out here. Again, fulcrum will be here. Effort will be here. And load will be somewhere in between. If you have an I bar, it's mid-facial. And again, that gives us class 2 lever rather than class 1. Okay? Does that make sense? Sean said, I thought that if the rest extended over the cingulum, even if it started from the distal, yeah, so that's something that was kind of new to me when I got to Maryland, that having this mesial marginal rich rest, having this finger-like projection that goes pretty much over the cingulum, we were calling it marginal rich rest at Maryland. To me, that was like, well, that just looks like a different version of the cingulum rest. If we're going to cover cingulum, and again, another reason I prefer this, take away so much tooth structure over cingulum, why not just do it this way? This gives me a lot to the metal. It's a lot stronger, a lot more rigid. That's why I like it this way. At Maryland, cingulum rest doesn't seem to be a popular option. So it will be distal marginal ridge rest on a canine. Let's see. I don't think I missed any question except last one. Can you clarify what you mean by long marginal ridge rest? Okay, so since we're getting the same question again, I'm going to check on this. Ridge rest, singular rest. Let me look at this and send you an email. Okay. If Dr. Frone calls what I've been calling marginal ridge as a singular rest, okay, never mind. I'll still look into it maybe. So let's go back. I'm going to turn on the light and get a little sip of water. Okay. Lost 10 people. Maybe we're talking too much. Okay, so let's go on. So here I was going to draw distal marginal ridge rest or singular rest. And again, I'll look into that for you. So I've pretty much drawn all the components right next to the edentulous area. Do you agree? So that next thing is I could potentially start connecting, drawing minor connectors and major connector. Now, when I'm drawing though, if I start off kind of finishing everything in this region, meaning minor connector comes off and it starts to draw major connector, and I go to the other side and I do the same thing. Sometimes if my line was off here, as I said, this is a little bit difficult to raise, so I connector here, okay? I actually do the other side, the same thing. So meaning I'm going to go to a single edentulous area and draw all the components right next to it, and then start filling in the picture, okay? So I'm back here. I'm going to do my distal marginal ridge rest, somewhat like this, okay? Now, because I have nothing else to draw, enter to these distal marginal ridge rest, I can actually connect this line. Why not? Now, when you do this, you can draw it in a way that it reflects the curvature of the arch, but somewhere in the middle especially, I hope you can have something flat, just gently curves to that distal marginal ridge rest on the other canine. So far, so good. I made a huge mess where it kind of looked like this earlier, okay? Now, let's look at the distal rest here. Now I can start to finish the line here. Now I'm gonna do this. Distal occlusal rest here. What else could I go to next? Could I go to anyone want to Rugae? Yeah, so on these exam sheets, we're not gonna really draw Rugaes. I'm not going to we're not gonna be hugely picky about the Rugae. Uh, but obviously I don't want it to be something like this or like this or like this. And you'll see why this is wrong in a moment. But try not to do that. I'm going to keep those lines so that I'll show you why that's probably not a good thing to do. So someone said TP plate. Yeah, proximal plate, I always find it a little bit difficult to indicate. But it's hard to indicate here. But one place you should certainly make a difference is at the very distal tooth here. So what you could do is you can draw one line here and just kind of a thick line over that distal surface of that tooth. And same thing here. And I have another line going right about here. Okay? And you connect these two to kind of indicate proximal plate. In reality, that's not how a proximal plate looks. But the way I'm drawing this will kind of show that I'm thinking about proximal plate as well as the retention lattice that's going to be on the distal side. So a little bit of bold line kind of gives me indication or a symbol that there's a distal guide plate, and then on another line, there's beginning of the retention lattice on both sides. Okay. Can I draw clasps now? I don't see why not. Now, I told you that there's no reason anatomically why we can't do patient. There's no soft tissue undercut. There's no buccally tilted tooth, frenum attachment. Everything is perfect. Everything is ideal. Okay, so I'm going to start drawing the eye bar. Well, the best place for me to start usually, I think about where the retention is going to be. Obviously, it's going to be mid-facial. Some people start with just tiny dot like that. If you want to do it that way, that's fine. Now, for exercise or simulation purposes, I'm going to draw a Rottweiler on this side so you kind of see how to draw Rottweiler. Okay? If you don't object, I'm going to do that. So I'm going to do my beginning of my eye bar here. Where should the eye bar go in terms of the way it's attached to the lattice? Is it first molar area? Is it between? Is it third molar? Behind the molar. So let's be specific here. First molar, second, and third. Behind first molar. And when you say behind, is it distal area? I hope you're saying. Between first and second, great. So everyone kind of remembers. So I'm going to end here. So if you drew, again, I'm just looking for accuracy. If you drew something like this, location-wise, this may not be incorrect. Why? Because I'm starting from mid-facial of the tooth. I'm ending somewhere between two molars. I find this a little bit problematic because in reality, eye bar doesn't curve this abruptly. It's not this is almost a straight line to me, even though it's curving. I'm looking at this. It comes out a little bit, and it's probably at almost 90 degrees from my eye because everything is curved. But something like this. When I was in a dental school, we had a quality control office, and this prosthodontist would always mark things. He said, the more information we have, the better. Thank you. You also get it wrong because you're drawing into the tube tooth. I'm also drawing in black. Yeah, thanks. You guys all caught me. I'm just testing you all. So yeah, so I used to my prof QA person used to write these things like 3 years. You don't have to do that, but I'm hoping you're not drawing something really close to the tooth, but it's gotta have a large curvature here and kind of tapering to the area between first and second molar. Okay. Yes, abutment tooth. Sorry, I made a big boo-boo there. Forgive me. Okay, we also need the retention line at the tip. Yeah, so the other thing some people do is they either put red arrow. See, now I made so many mistakes here, indicating some sort of undercut, or they simply extend that blue line. Wait, it's not tapering, by the way. It's thicker. So I'm going to correct my mistake here. So we had two tooth here missing, and then I had distal occlusal rest. Good practice, isn't it? And then two tooth, distal occlusal rest. I can connect this to that, and I'm not going to draw yet. Dotted line. Sorry, that's not. Should be closer to the tooth. And thick line on the buckle to finish. Okay. Man, I keep making mistakes here. Side plate. Beginning of the lattice. Mid buckle, that's where I'm going to start. So here comes my retention indicated with that little line we have. And someone pointed out, well, it should kind of taper. Well, it shouldn't taper, but it should be kind of thicker when it's going to the lattice. Yeah, I agree with you. I'm going to draw something like that, maybe. Can you see a little bit of thickness toward the teeth? Erasable blue color pencil. Damn it! All right, I'm done making mistakes. Yeah, teacher of the year, huh? Two tooth. So if you put I-bar or any clasp on a two tooth like that on your actual practical, you're gonna get a lot of points off because I already shown you twice that you shouldn't be. Am I embarrassed? Nah. Make mistakes. This is how I'll get better. Putting up with me. Okay. I'm expert at this part. Okay. Maybe let's start with that. Okay. And start with that. Is that good enough to say this is how we're going to prevent drawing the eyebrow in the wrong place? I think so. Putting the retention or indicating the retention before I start drawing it. Okay, I told you I'm going to draw a Rottweiler. Rottweiler, the way it's usually drawn, because it kind of wraps around the tooth, I tend to kind of draw a thick line, but it's not coming off the tooth. And it has to continue over the lattice somehow, and it's going to go somewhere near the distal portion of the tooth on the first molar, somewhere like this. Why do we draw it this way with this big circle here? Well, that's just kind of a symbol to indicate it's being soldered to the lattice. Rottweiler is added after whole framework is made cast first, and this portion is soldered to the rest of the framework. What else did I do wrong here? Well, Rottweiler, usually the retention isn't usually in the mid facial, right? So this should have been indicated here. So can I just emphasize that please practice before? I practiced mid. I actually didn't practice. So I'm making a lot of small mistakes here. I told you that neatness counts toward the group. Having something like this, I've seen a lot of the following. Sorry, Dr. Choi. I'm sorry. I'm sorry too, because you're starting to make it really messy. you're going to get points off for not having neatness. Okay? So far, so good? I've done pretty much everything. Guide plates, okay? Now, guide plates around the tooth teeth, you can do it if you want, but because of the minor connector and everything, up to you. But if I wanted to do it here, I can. Lines again. All right. I'm pretty much done with everything I can think of in terms of sort of the small components. So now I can start drawing the big things. Can we please get one courtesy mistake for the practical? Comes from the person who I think of as a perfectionist. Yeah, the answer is no. I'm gonna get murdered by class of 2020, 2021, 2019, and so forth, because I didn't give them any courtesy mistake. Yeah. So yeah. So sorry, no courtesy, just practice. It's what separates from boys, right? Anyways, I'm gonna continue drawing. So I'm kind of done here. Extend the minor connector now. I'm confident now that I'm not gonna make any more mistakes. I don't even have to hope. Remember, this has to come around in a circle, kind of a curve, okay? Oops. See, the more, it's like when you watch great chefs or like a sushi chef, for example, they make the economy of their movement is amazing. They don't move very much. It's just, or even artists, they move once. Painting, it's just one or two strokes of the paintbrush, and they really don't make a lot of mess that way. So any places that I've been drawing one line only, I'm a lot of mess. Here I'm starting to make a little mess there. Is that okay so far? I mentioned to you earlier, if you drew anterior portion of this major connector in the palette, if you drew something like this, and let's say, question is it the proximal plate that extends becomes the external finish line? Yes and no. The external line, in a sense, is not really part of anything. It's just part of the framework. But proximal plate and those two, they don't really connect to each other. I mean, you could draw a line and they will connect, but they're not really. In a 2D drawing like this, it may appear that they're kind of part of it, but just think 3D, because external finish line is much lower, and then have that. Do you want a foot portion coming off the proximal plate to be Dr. distinctive? Drawn distinctive. So this is what I'm drawing here that should be kind of distinctive. But in fact, if you think about the foot portion, and again, that's very difficult to draw on a 2D. But I'm just looking, if you draw at least a thickened line for the guide plate and what looks like the beginning, a line to show the beginning of the lattice, that's all I'm looking at, okay? And again, that goes to someone else's question. That's, showing the external finish line, okay? Can we put AP palatal strap there? Because my question was, what kind of major connector options do we have? AP palatal strap, absolutely. No reason why we can't. Is guide plate and proximal plate the same? They are. Good question. Any other major connector option? Again, we're reviewing almost everything here as I draw from little to another little thing. So far, we got AP strap, which should kind of look like this with a large enough circle in the anterior portion. Okay. And this portion should be at least about 8 millimeters, and this portion may be 10 millimeters at the minimum. You don't have to write that, but I kind of look at, yeah, palatal plate is another one. I kind of look at the drawing and see if you kind of drawn things more or less in a good proportion. So if I had drawn that angle of the palette this way, and my opening on that major connector is very close, like this, where this just doesn't look like 8 millimeters at all, I'm going to say, put a comment and some points off. Because again, it's difficult to draw that, but I want you to be just kind of very clear with your, very obvious with your drawing. Excuse me, where there's plenty of bulk here. And this looks like this, which is kind of reverse of the anterior curve, where it's going inward a little bit or mesial a little bit, and this is as straight as it can be in the middle section and comes to the point. Okay. Remember, this area is pointed because this is an area that kind of extends to the hemular notch. If I see a drawing that goes like this, kind of extends, I'm okay with that because in reality, yeah, this point actually has to go into hemular notch accurately. That way we can have a good support from that area. But this is what I'm looking for. And again, this is getting messy, so I'll pick another sheet. In the meantime, ask any question. Sorry, it's almost 4 already, so we're kind of getting close to finish. So one more time, I'm going to see if I can draw without making any mistake. Edentulous area, tube tooth. I'm going to have a distal occlusal rest here. I'm sorry, mesial occlusal. I already made a mistake there. Distal marginal ridge rest, or dotted line for the tube tooth. Same thing. Tube tooth, dotted line, second line here, MO rest. Now onto the major connector, straight line, curving to the single or the rest. I'm going to indicate my retention there, retention there. This is my end I bar, so it comes around like this. My draw, not perfect. I'm doing a lot wire, as I mentioned. Could you use, do you care how big that circle is supposed to be? Yeah, bear with me, I'll answer that. This may be neater this time. I haven't had lunch, so my brain is starting to tell me I need to. Not yet. Distal guide plate or proximal plate. Sorry, I forgot that. And that begins the lattice. That begins the lattice. Mistakes yet? Hopefully not. Okay. That's all the way back. All the way back. Good thing about this design, as I said, it should be symmetrical. Curving. Somehow I have the strength to breaking pencil. Okay. So far, okay. So if you stop here, you're not quite done yet because you got to draw the lattice. Okay. Lattice, I like to see the lattice portion not straight, not completely over the center. It's got to go over to slightly to the buccal. Just imagine how would the teeth be retained only to the middle? The buccal portion of the teeth will basically be sitting on nothing. So you got to do this. Now I'm just going to come around. We don't need to go to third molar, obviously. And I can do the same thing on this side. Okay. Now, I've seen all different variations of lattice, but simply if you just drew a bar running this way, and then a couple bars just to create windows. That's all I would expect to see, something like this. Now it's not perfectly symmetrical, but yeah. And then there should be another thickened metallic line on the outside of the lattice. Okay. Let me, yeah. So I'm gonna start answering questions. The line you're talking about, these lines, I hope. The only portion that's kind of flat is in the middle of it. You know, elsewhere, everything you should have some curve. AP palatal strap, draw a circle that is 6 millimeters wide in the back, 6 millimeters wide on the side, 8 millimeters wide in the front. Hole needs to be at least size of a nickel, if not a quarter. Yeah, ideally, if it can be a quarter size, that would be good. Imagine, okay, so I'll ask you some questions later, Ilana. I'm going to put you on the spot. Do you have a preference where we do retention, mid-buccal, mesial buccal? If it's a, you've got to put it on mid-buccal. That's our philosophy at Maryland. Okay, if it's a mesial buccal, it's going to look like a Rottweiler or some sort of Super Bowl clasp. Unless the case says palatal tori or torus, could we always use palatal plate for 1, 2, and 4? Answer is yes. Can we use our regular pencil if we don't have colored pencils? And so if you don't have colored pencil, you should, I think Dr. Frone sent out an email. The reason why we initially didn't want to do it over the web online is because we wanted you to be here with colored pencils. I'm not sure if you would all have it. So if you couldn't get it, maybe the school would provide you one. But yeah, you've got to have the blue and red pencils if you could. So I answered that. Don't worry, I'll get to your question at the end. Blah, 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 blah. Do you care how big that circle was? We already talked about that. Yeah, so that circle, you know, if I drew it just based on someone's mentioning of the numbers, I'm gonna look at this. I've got a nice width here, nice width here, here. That's what I'm looking for. I drew something smaller than that, larger than that, you know, it's just not gonna be the one I'm looking for, okay? If you stopped there without the hole to kind of accommodate torus, well, this patient I mentioned doesn't have torus, so you don't have to do that. You stop there, you're done. Why make it complicated? But just for review's sake, why would you put this here? Why would you take away the middle? If the patient didn't have a torus, okay, heavy, hygiene. Remember, it's going to be a foot trap no matter what. Okay, I can say there's some argument to weight of the material. Tissue health, yeah, potential comfort is probably number one. So Kevin, you get bonus point second time today. Because patients do like having less material if possible. If it adapts in this region, they love being able to just have something that's their own rather than having something metal that covers their palate entirely. Tissue health, and again, if everything's kept clean, yeah, but tissue health will be affected no matter what. Can I use blue and red pens if I don't have? Okay, so here's my answer. Someone asked, other than this, what is red used for, or where would I use red? If you wanted to say this is 2 tooth, do it with red, okay? If you wanted to indicate undercut for this area by saying 0.01 inch, do it with red. So same thing, Rottweiler, what's the undercut? Thank you. Am I losing people right now? Been a long day, huh? Inch, thank you. Okay, still 75 people, not bad. So is it not necessary to draw out undercuts? Oh, my video has been showing the whole time. So it is not necessary to write out undercuts. Write it out. the undercuts and indicate tube tooth. That's the least I will ask. You don't have to write mesial buccal, mid buccal, things like that, especially because you have indicated. But again, make it clear that the drawing of the clasp is coming to the middle of the tooth, not mesial or distal. But just other than this, there's nothing really else you need to write. Again, I'm not asking you to write down the dimension in millimeters of these straps. Again, that's going to make the drawing a little bit kind of complex looking, busy looking. You're going to enforce the 3 millimeter rule for lattice depth. Are you talking about this thickness here, Bo? The thickness of this each lattice? Between the lattice and major connector border. So between this are you talking about this distance? Distance of the external finish line. I don't know if I'm getting that. All right, someone needs to draw this for me. I'm failing you all fast. So can you draw and share with us? The 3 millimeters still doesn't, there should be, I can't imagine what is 3 millimeters in this, because this should be at least 6. Kevin, for now, I'll run it by Dr. Fromm. No, not a dead horse. Horse is still alive. Yeah, so this is required. Now, if it changes, I'll tell you, but I got to run it by Dr. Fromm. Okay. Someone spoke up just a moment ago. Is that you, Bo?
Hi, Dr. Choi. It's me.
Hey.
Okay, so
share your screen.
Well, sorry, I don't have anything put up, but I was referring to the lattice where distal extension, how wide that horizontal lattice, that framework. So you mentioned
everything
6
is horizontal. So are you
millimeters.
talking about this horizontal?
So it's 3 millimeters from the edge of the tooth or the gingival margin, the fake one, to the major connector. So if it's more than 3 millimeters, I think Dr. Fromm mentioned on my project that it might be like a patient discomfort issue. But on the other part,
this space right here. I think I'm getting it now. Is that right?
Yeah.
And you got, so she said 3 millimeters is minimum distance?
Maximum, actually.
Maximum.
Or a perfect distance. Yeah, so in that case, we can see that, and what on the anterior where there's no lattice, so we have 6 millimeters for the maxilla, but whenever there is a distal extension, it's going to be 3 millimeters for the ideal, width. So I imagine if she was grading it, there's going to be a difference.
She's not grading. I'm the only one. So this is what I'll do. So it's a little bit different from how I was trained. So I'm going to run that by her too. Okay, and I'll get. But that's probably not something that you should really be concerned about at the moment. Because one, I'm not going to take out a ruler and measure this and say, well, Bo, you're at 2.5 millimeters, so, or you're at 3.1, so you lose a point. You know what I mean? Yeah. I need to keep going because I'm afraid we're going to run out of time. It's already 4. Is everyone doing okay here? So imagine just this was all filled out. Okay, nothing empty. Okay, we got to get to the writing part of it. What you need to all write is please fabricate maxillary partial framework, you can do a symbol like that, just not wanting to take any chances with all these abbreviation and whatnot. What you can do is you can just say a max, spell it out or write it out, maxillary RPD to the following. So I don't have the greatest handwriting, but if you can read it, I can read it, that should be fine. So nothing crossed off so far okay, right? And here it's just doing the exercise again, kind of, but you're just putting everything out verbally. So you're gonna start with, again, this is in particular order. If you follow the order that we follow in terms of drawing, that'll be fine. If it's out of the order, I'm not gonna take points off for that. So again, I'm gonna start with something big. In this case, major connector. And again, you might start with REST, that's fine. Make sure you write down what you exactly drew. You know, if you drew AP strap, you can't write palatal plate, okay? So whatever, okay? And I'm going to write next, REST. Okay. You should be indicating all the teeth. So on 4, for example, that was MO REST, 4, MO. Okay. 6. Again, I'll run this by Dr. From. If she called it cingulum instead of distal marginal ridge rest, that's what we'll call it, cingulum rest. And the same goes for the other side, okay? For the time's sake, I'm gonna just keep going. Proximal plate or guide plate, they're all fine in terms of terminology. Okay, I'm gonna write on 4, we've got 2, because we got this plate here facing the edentulous area and this facing the tube tooth. So I better be writing 4, and I can simply do mesial and distal, okay? 6 should have a distal guide plate, okay? 11, same, distal guide plate. And it's the same on the other side, except it's on tooth 12. Okay. Did I mess up again? Yep. 13. The monkey keeps falling off the tree. Clasps. Okay. On 4, I bar. Am I done here? I'm just gonna write 13 wire. Am I done if I write like this? When you say a question privately was, can you just type in 13 MD plus? MD makes it sound like you got a rest completely connected from mesial to distal. So I would say plus or and. Yeah, we've got to indicate undercuts. So I would say I bar. Where was the undercut? Well, mid. I took, last year there were a lot of points lost because people drew a mid buckle perfectly fine, and when they were writing it down, it was not consistent. It would say mesial buckle. So you gotta be consistent and accurate throughout. Mid buckle 0.01 retention. Okay, just gonna abbreviate. I don't know if you can see all that. Right, obviously mesial buckle. Okay, Rottweiler goes for 2 retention, something like this. Okay, so far okay. What else is left? So I've basically done everything that's very obvious in the drawing. What else is left to draw? I didn't. Yeah, so 11. I didn't write those because I was just trying. 13 MO. Yeah. Great. Tube tooth. Okay. You can simply just say base because that covers basically all the edentulous areas. Where? Well, starts from, you can start from one side and work your way around. And that's how I usually do it. I can say, areas 1 through 3. Actually, we're not going to put a wisdom tooth. I'm not going to take points off of that, but I hope you say 2 and 3. That's a retention lattice. Complete phrase would be acrylic retention lattice. Okay. And then I'm working my way toward the tooth there. So I'm gonna say tooth on 5. Okay. Now, because this is perfectly symmetrical bilateral design, what you could do is you could do tooth 5 and. Right? And you can also write here 14 and 15 acrylic. I'll show you this section of the page in a moment. I know it's 14 and 15 acrylic retention lattice. Okay. Is there anything else I might have missed? I can't think of one. Yeah. So in this section, I'm pretty much done. Metal used. I still remember some of these answers were very creative. I had diamond, I had zirconium, I had titanium. Do you all remember what metal we use at our school at the least? Zirconium. Vitalium is another for that, but just keep it simple. Zirconium. Okay. My signature. DMD. Okay. Return whatever date. Okay. 2021 on COVID. License number, whatever it is. So nothing is left blank. Okay. Vibranium strongest and no. Yeah, just don't do any other metal than zirconium or vitalium, not vibranium. Or what is that metal that Wolverine has? When you're done drawing, can you zoom out so we can take a screenshot? Can I just scan this and send it to you? Adamantium. Yeah, there you go. Because the camera actually probably won't zoom out. This is as far zoomed out as possible. So you can only zoom in at the moment. So John and everyone else, are you guys okay if I send it, scan it, and send? Yeah, thank you. Let's see if there's anything else that I didn't cover. Everything should be filled out, in case people are joining now. I hope they're not. In the meantime, type away questions. Can you please email the recording? Yeah, good question. The recording takes about 24 to 48 hours because it gets processed in the cloud. So as soon as it's available, yeah, I'll put it up. How will we be submitting these designs if you're doing this exam online? So that's, you got to look at Dr. Frohn's emails, and can you let me know if that's still confusing? You got to look at her emails. I can't tell you exactly what to do. You got to go by what she said. What if the photo doesn't do justice to our drawings? Should be, some of these logistical, technical questions, I don't have a lot of answers. You are in the history of the stethoscope for do this practical exam online. So we're bound to have some issues. I think we're all technically technologically savvy that I don't think we're going to have a huge issue. They will be uploaded to Blackboard. As far as how you've been uploading things for other courses like the fixed course, I feel like you've been just doing just fine in terms of what if you had to draw anything or handwrite. Can the written instructions be written in pencil for, yeah, just so that you can erase things? Yeah, sure. Or just don't get it wrong. No, that's probably unusual. But yeah, I mean, you know, in the past, I was paired up with another instructors, and someone even took points off. You know, your 3 kind of looks off. Why doesn't it need 1 point off? You know, if 1 point you're still getting an A, I don't know. I'm not going to go there. If the design has bracing arms, do include those in the written part? Absolutely. I took points off for that a lot of times because the bracing arms weren't indicated. While you guys still type away questions, yeah, I think someone says say thank you. I have to write that. You don't have to write that. That's kind of optional, but nice professional courtesy. I'm just trying to see if I miss anything. Anything else? Yeah. Yeah, absolutely. Because when you write anything about the class, you know this class on tooth, for example, is retentive class because you're indicating where the retention is and what depth. A bracing arm, you're just going to write, if there was a bracing arm to 4, you just write 4 bracing arm on the palate, or just write palate. When you write in the bracing arms, is it the same as for the retentive arm? Yeah, exactly. So you could write 4 bracing arm, hello, something like that. Is that clear? Sometimes don't even care that you don't write arms in the actual written prescription, but again, we're looking for completeness here. So if you write it that way, you're fine. I might run this by to her too, because I'm not sure if she took points off in the past for bracing arm stuff. Any other, if you don't, will we have designed just 1 arch? I believe it's just 1 arch, unless you want to do both. I don't think anyone wants. No, if you did both, if there are 2, you would have to do it on a separate paper. You can see how well populated this becomes. It's just impossible unless you have a perfect handwriting, which I don't. But just if there are 2, actually I don't know. If there are 2, you got to do it on a 2 separate sheet of paper. I got to share one more thing before I go. It's this. You know, this is my grading sheet. Okay. So to go over this, and again, it's kind of review of the design principle. It doesn't show any. Again, if there's any class 1 lever in your drawing, man, this breaks my heart usually. Not just because we talked about it so much and you kind of missed it during the exam, but also it's 30 points. So no matter how well you do in the other part of the drawing and writing the prescription, you're down 30 points. Another question coming this way, coming my way. Can we have a separate session? Mandibular arch. So I'll answer that later. This may be an awkward question, so bear with me. For class 2 example, using Embracer class. Oh, I'll answer that in a moment. Someone sent that to me by email. So the other question was, can we do mandibular arch? So my life so far has been hectic. It's about to get really hectic now because we have been just, for you guys, especially in the fall, for some of the didactic courses, we have to prepare for 100% virtual courses. So now I have to go start creating all the content in a virtual format. And they're online, but not 100%. And I was told any recording we use on a media site, we can't reuse, which means you get to hear me fresh recorded, same content though, but everything is freshly recorded. It takes hours to do that. So for that reason, my schedule is about to get really hectic. And next week, I'm here 5 times a week too, because some of you in the D4s are here. So my time becomes, actually next week doesn't matter because of practicals next Monday. So let me think about this. I'd love to do another review because, not all of us was here, and some of you left because I've been just babbling so much because I wanted to give a comprehensive review on this. So I'll get back to you, but I got to get through some of these questions to Dr. Frone and work on. Yeah, it's sometime next week, isn't it? I scheduled this at least a week before, so I know it's sometime next week. Just look at the email, look at your calendar, all the logistical stuff. I'm not here to make you all confused or give you a review on that. What are the checkpoints we should go through to ensure you don't have? Well, it's exactly what I reviewed earlier, early on. You got to make sure when you have a distal extension or some large area, it's not tooth bound. You got to make sure you're not putting that rest that creates from right in the middle between effort and load. You do that, you're bound to have a class 1 lever, and you get 30 points off. That's the first thing I look at on every single paper. You can email me any. No, we'll go over that questions quickly, because this will be another 10 minutes at the most. So this is the grading sheet. I already mentioned 30 points off for class 1 lever. Everything else we already went over. Okay. People. Conceptual. Yeah. Yeah. Great question, and that's what I wanted to talk about too. Where conceptual. I saw that too. Where did I? Oh, yeah. Okay. So drawing on the CAS versus conceptual design on the CAS. Well, obviously, it's going to be on paper only. Conceptual design is the following. Here's an example. So if you gave me class 1 lever, that to me is a conceptual mistake, conceptual error. So under clasp, you're going to get points off. You already know it's 30 points off. I'm not going to take another 30 points off for having a distal occlusal rest and a distal extension. I'm sorry. So any part of the clasp assembly that creates class 1 lever, it's just 30 points out, and that's it. Whether it's position of the rest, well, that's pretty much it, right? Because you put the rest right next to the distal extension. Class-wise, here's an example of what conceptually a mistake might be. Mid-facial, if you didn't put it there, it's a conceptual mistake in my opinion. Drawing-wise, if you wrote on the prescription that you wanted mid-buccal retention for I-bar 0.01 inches, but on the drawing you actually put it on mesial buccal, that's a drawing error. Because I see that you understood you were prescribing a mid-buccal I-bar, but you just drew it wrong. So that's a drawing mistake. I'm not going to take the points off. Conceptually too. Now, if you also indicated the I-bar has retention on mid-buccal, mesial buccal, now you're getting, and you drew it on a mesial buccal, you're going to get points off from drawing design as well as conceptual design. Okay. Neatness only goes to drawing, obviously. So everything else is about the same. Major connector, you picked, full palatal plate on a patient with a torus. Okay, that's a conceptual mistake. But if you drew it well, I'm not going to take points off there, just because you conceptually. Otherwise, you drew a major connector that is, full palatal plate, but conceptually or in your writing, you said AP strap because you read it correctly that the patient has a torus. You just get points off on a drawing. Okay. Mouth preparation, there's no really preparation there, but it's just going to the drawing and the lab written prescription again, guide planes, res, and things like that. Accuracy, completeness, this again is going to everything I mentioned. So everyone starts at 70. Even even if they turn in a blank form, I guess. No, that's not true. You would actually fail because you just keep accumulating negative points. Yeah, just remember, 30 points, please don't do class 1 ever. Please don't. I just want you to do, everyone to do well, and it starts from that. Once you have that down, and everything is neat, everything is accurate, complete, I don't see why we can all get A's on this. Okay? So I got to do one more thing, and we have to close. And for mandibular arch and other questions, maybe we can do it on another session if I can find time. And I thank you all for being here. I got to find that question. I printed it. Here it is. And this might go to that anonymous, I'll just say caller, someone who asked me this question. According to I can go mid-buckle, mesial buckle. Are you saying that? Yeah, we do mid-buckle only usually. Again, there's exceptions, but very few exceptions. We do almost exclusively mid-buckle if possible. You're welcome. Okay, so this was emailed to me, and the student asked me, well, first of all, this is, as you know, class 2 candidate classification with, I have to remember, no mod. We don't see any tooth missing here actually. Without really thinking about what you memorized or what you might have memorized, where candidate class 2 should have attentive class, even before going there. Okay, let's just look at this area specifically, right? Tooth 4 and 3. Again, I'm going to mention the class lever idea. In order to do that, we got to think about the fulcrum. Again, depending on where we are and where the occlusal load is, the fulcrum can be different. But in general, for class 2, here's my fulcrum line. Okay, through the rest, the distalmost tooth there. Okay, and then through the distalmost rest here. So around this line, it's going to rotate. Geez, hold on. Now, which way will it rotate? Well, it has to do with where the edentulous area is. So imagine I'm just grabbing this partial. It's going to rotate toward the paper, toward that one edentulous area on the right side of the page. Does that make sense? Okay. When that happens, what happens to this side? This side lifts. So on tooth 4, it lifts this way. So if I have a clasp here and the fulcrum, so clasp here, that's my load. Fulcrum is behind that load, okay? Effort is in this edentulous area. So the order is, if you wanted to pull for your, just the order of the class lever, effort, fulcrum, load. Class lever do we have? I hope you all say class. Correct. So then, when would this class be wrong? Now that's, I think, better question than saying, should we have class there or not? Should we have a class there? If you say no, you probably mean you don't want a retentive class. Exactly. If we have a non-retentive class, you can put a class there if you want. You can put it there, okay? Yeah, exactly. So you end up having kind of a bracing arm. Now, usually, if we have a component, if it's not retentive, we got to balance that. So we got to have another class. And again, these of them will not have any retention. Yeah, so all of you are saying the same thing, all correct. Exactly. Anonymous caller, you are correct. There should be retention only indicated by this little line there, distal buccal of that molar having retention. This shouldn't be there, okay? Now here's a follow-up question. When do we not want to have a clasp, even if it's non-retentive? Meaning you take that away, which means you have to take away the bracing arm too. When would you want not want it? This is why I love RPD, because there's always something else you can think about. And unless you start doing RPD, you just won't get some of these nuances. Is the patient having difficulty taking the RPD off? Probably not. When you look at the class 2 situation, this is not a lot of hardware. When indirect retention is needed, okay, do clasps, whether it has, if it doesn't have retention, does it provide any indirect retention? So this is another review. I'm so glad, Cash, that you brought this up. I love that question. In all practical purposes, what part of metal framework is actual indirect retention? Not clasps. It's usually the rest that are from the fulcrum. If some of you are really shy, feel free to speak up. I mean, there's no reason. Maybe this reflects how you are in a real environment too. You know the answer, you just don't speak up. You're always right, but you just don't want to admit it. Rest away from the fulcrum line. So if I had a rest here on 6, that would make it, okay? Before I get there, so I gotta mention, no one has really answered why I not put this clasp there. Like Jasmine, just really booming big smile, and it shows all the way to the last molar she has to the other side. That clasp will show. Will the molar show too? Yeah, possibly. But if you think about some aesthetic concerns, I would take that away. If you take that away, take away bracing arm, because you don't need it, okay? So aesthetics is always a concern. Sometimes we're just splitting hairs. Having that little dinky thing, does that really affect aesthetics? It really comes down to subjective opinion. Patient wants it, patient doesn't want it. Let's go to this, because another question was, we already talked about this. Why wouldn't I put it here? So hopefully this is the last thing I'll ask. Maybe just to test everyone was awake, paying attention to my babbling. Why wouldn't I put this here again? The mesial rest from the mesial side. Why would I prefer the distal one? Yeah, it's a patient comfort. There's no pushing. Yeah, patient comfort mainly. Not having this, again, this clearly shows whoever sent this to me, Hope, thank you, really drew it well. Having this little bit more metal can make a big difference, because it's starting to really interfere with the anterior teeth. Okay. Okay, I have to stop. If you have questions, you have to email me. I'll also email you whether we're going to do this for much. It all depends how much work I'm going to be given. All right. I have to say, I'm so glad to see a lot of you were here, not because I wanted you to be here, but because it means that you're all safe and sound in this crazy time. If anyone is going to or went to the protest or is planning on going, I hope and you do it safely. Otherwise, thank you. And I'll see you later. Okay? Bye, everyone.